Hello, welcome to our second lecture. Today we're going to talk about an introduction to neuroimaging and we're going to focus more on CT. As we discussed last time, CT is the most frequently used modality and the most accessible for neuroimaging purposes in the world. So I can guarantee that a lot of the patients that you're going to be seeing in your daily practice will have some sort of imaging that will include a CT. When we're talking about neuroimaging, of course, imaging of the head with a CT is the most frequent one that we're going to be looking at. One very important concept that you need to understand when we do CTs, which again is based on X-rays, is that CT has too much information than the one that that can be displayed for the human eye. The human eye can only see so much of the information that you get with a CT. So we have to display the Hounsfield units, which are the grayscales of CT, by using some tricks, which we call windowing and leveling. So it is impossible to just read a CT of the head using the one displayed image you have, because you would be missing a lot of the lesions that you have underneath it. Then today we're going to touch base a little bit on windowing and leveling. Uh, what we call when we say level, we're saying the Hounsfield units of all the numbers within the window width that we have. We're talking about width. It's all the tissues of interest that are displaced, and you can change the contrast between them. And we're going to see a little bit about that later in this lecture. So the objective is to review the principles of the CT of the head, explain how the different windows work and why they're important clinically. We're going to have a very specific lecture on brain trauma that is going to explain why this is so important. We're going to talk a little bit about how we can reconstruct things when we do CTs. We're going to do a brief introduction on the basic approach and how to evaluate a CT of the head. And then we're going to just mention advanced post-processing, which has a lecture of its own. And we actually have a whole center dedicated here in our hospital to doing volumetric and quantitative images based on neuroimaging, and CT is a huge component of that. So CT of the head, as we mentioned before, is the most utilized. But how much is that? So just in our hospital, we roughly do 30,000 of these studies per year. And we have like 14 CT scanners in our core hospital, which is a very important number of CTs that we do. Compared to MR, we do roughly twice as many, if not three times as many CTs that we do of MRI of the central nervous system. It is a great tool to look at the bone, as we discussed, but also is the first imaging modality that we do when we're examining the brain. So to target any complication or any disease inside of the brain, we usually use CT as the first tool. So this slide was present in our previous lecture, which kind of tells you that what the units that we use to describe densities, hyperdense and hypodense on CT, which are Hounsfield units. Mostly when you're doing windowing and leveling, if you can imagine, and windowing and leveling is how wide you want the window that you're seeing or the level to be as you're displaying the images that you're watching on your PACS or in your display tool. You know, when this is where the grayscale is, and some information, anything that is darker than this will all be displaced as black. Anything that is whiter than that will all be displaced as white. So there's a lot of information in the tail ends that can be missed unless you adjust your window and level to see the disease that is within it. And that's what we're going to be discussing today, and that you're going to see in some of the cases that you'll see in the course as we look at disease. So these are the four most frequently utilized windows that we have in neuro imaging. So this is what usually the scanner kind of throws at you. which we call the soft tissue window. It's kind of good for everything. You kind of see the bone white, gray white matter differentiation roughly, and you could see some of the extraaxial spaces, but it's really not easy to do so. Then we can adjust the kernel, which is the algorithm, to really show you a high contrast between bone and soft tissues. And this is what we call our bone window. And we utilize bone windows to look at bony structures. In the case of trauma, for example, to look at if there are fractures or not, or if there's any lesion inside of the bone. But when you do a bone window, you really cannot see a lot of the contrast that is happening inside of the brain. So it makes it a little bit tougher. Then we can also do a highly contrasted image that will allow us to see blood products whiter and the brain parenchyma darker. We call that a blood window. Some places will call that a subdural window. And it is very important to do this because sometimes you have bleeds in the periphery, and mostly the ones that are in the periphery of the brain, that could be hidden because of how white the bone is. So unless you do a window like this one, you could miss that there is a lesion here, and you can really see it much better right there in the white, in the blood window. Let me see if I can demonstrate it for you right here. So you can see that little bleed that was otherwise easily missed if you just use the other two windows. And then we use this last window where you see just a better contrast between the gray matter, like in the cortex, and the white matter. And that window, since we're looking for gray-white matter differentiation, and if you remember the previous lecture, that is very important when you're looking at stroke, because in strokes you have blurring of that gray-white matter differentiation. So typically when you read a study, we try to read it in the soft tissue, in the bone window, in the blood window, and in the stroke window to make sure that we're not missing any lesions because of just looking at one. And this is very important. You can imagine if there's a little fracture here, you couldn't see it unless you had this window. If we had a bleed here, it's easy to miss if you didn't have this window to really show you the blood. And if we had a stroke, which we don't have here, it would be much easier to miss if you didn't have a dedicated window for that. So how do we change the windows? This is not something that you guys are going to be doing at this level, but how do we do it? So when we're in the packs, we have preset windows in our packs that allow us to see it, but you can also manually change the window and the leveling. And you can go from this typical image, which was the one we had, to go down to a blood window to detect the two spots where you have bleeds that you can see. Let me magnify that for you guys a little bit better there. Now, why are these things important? Well, this is a case where we have a patient. You can see that the structures of the midline are tilted to one side, and there seems to be a high density that is happening back there. But you really cannot detect what is going on really, except that of the high density in the falx and then kind of white blob that is going on there. You're really suspecting or sure that there is a bleed, but in order to really differentiate the bleed from any other structure that looks like bone, for example, you need to window the level of the image, and then you can really see where the blood is, and you can differentiate the blood from the bone. So you see this, and you see that, and now you can really identify bone flood blood. Amazing. It's almost magical. So if you don't do this, you're going to be missing a lot of disease when you're interpreting these images. Typically, when you see a board case, they'll give it to you in the ideal window where you can see the disease. But for us in our daily routine, we have to do this to not miss lesions. Now, if you go to the stroke window, which will really give you a much better gray-white matter differentiation, you see that there's kind of something dark here that you cannot see that gray-white matter differentiation well, But once you do the stroke window, the contrast increases and you can really see that there's a lesion on the image that I have here on my right side. So that is how you would look for a stroke. Remember, we saw one of these in our previous lecture. Now let's talk about bone windows. So we saw that the stroke window and the blood windows are important. In this case, we know there's a big bleed. Remember, bleeds are dense iron, but we do not know really what's going on in the skull. So we need to have this contrast between the bone and the soft tissues. And here you can definitely see that there's two fractures that are clearly identified that otherwise you would have not seen if you would have not done that window. So when you want to see bone well, you need this very high contrast and crisp image to tell you that difference. Why should we always look at all the windows? So this is a nice case to give you that example. So here we have the soft tissue window, and here you have the blood window. And what you are seeing there is that there is possibly a lesion in the convexity on the left side. You can see it right there. This could be blood. We said it was dense, or it could be something else. But how can you know? When you do the bone window, you see that there is a disruption of the normal architecture of the bone. So this is actually a tumor that is invading the bone. We can see it in the MRI later. You see this is the tumor enhancing. But tumor in this case would have looked just the same as a hemorrhage, and you could have let the patient go home because he had a subdural hemorrhage if you only relied on two windows. But once you do the bone window, you say like, oh gosh, there's really something going on in the bone, and you think about another diagnosis. So that's why in all of our patients, we have to look at all windows, and you have to know that at least you have to see them when you're looking at that. There are multiple papers that tell you the use of narrowing windows to improve your detection of disease and stroke. Now, let's talk a little bit about reformats. Remember that we said that initially CTs could only be seen in the axial view. But since we started doing isovolumetric voxels, we can reconstruct in any plane that we like. Is it sagittal, coronal, or oblique? And these are examples. So when you do CTs in the modern era, you're going to be also seeing coronal and sagittal views, if you may, which are really reconstructions of reformatted images and not only axials. So get used to that and be sure that you can see this. One of the most important things when we're doing CT before we look at lesions is what is normal and abnormal of the ventricular size. When ventricles are too big, it typically means that there's an accumulation of fluid within them, and we tend to call that hydrocephalus. But also ventricles become big when the volume of the brain decreases. It can decrease because of age or because there's a disease that causes atrophy. And we have to kind of know what is normal and what is abnormal. Here we have a 57-year-old patient, and you can see the size of their ventricles. You can see also how prominent the sulci are. Is this normal or is this abnormal? You have to know the age of the patient and what normal or abnormal looks like to be able to make that call. In this other case, this is also a 57-year-old. You see that you can barely see the ventricles at all. You can barely see the sulci. The sulci are all effaced. So this is extremely abnormal. So the first case, the patient had prominent sulci and ventricles for his age, and this one is too small. One case was a patient that had chronic renal disease that had atrophy of part of his brain parenchyma for the age. In the second case, this is a patient that had trauma, and because of the trauma, he did diffuse edema of the brain. And we're going to talk a little bit about edema. And this is this case. The patient has just diffuse edema of the cane. So let's talk about in CT about brain parenchyma. So when you look at a CT, the first thing that you have to see is how is the brain parenchyma. You have kind of two options when you look at a lesion in the brain parenchyma. The first option is that you have a lesion that is going to be, let me see if this works. You have a lesion. And that lesion can be either white or it can be dark. So it can be white or it can be dark. So white lesions is what we call hyperdense lesions. Remember, this is CT. And when you have something that is hyperdense, we think first and foremost about blood and blood products. Why? Because of the iron. We said that before. So acute bleeds can actually be seen as very, very bright. There's an exception, and we have a very important trauma center in our hospital. And think about it. When can you have acute bleeds that are really not hyperdense? That's kind of the same as asking you, can you have acute bleeds in patients that have low iron in their blood? Yes, they can be anemic, but when do you think a trauma patient really gets here and you can have bleeds that are not that hyperdense? Great. So if the patient had fluids in the field and had a big trauma, when you do fluid replacement because lost blood, they put lactate, they put saline. These things do not have the iron that you have in blood, so you can actually have acute bleeds that are not as dense as you would expect because of the lack of iron. So remember that in CT, it's the iron that gives you the blood. But there are other things that are very bright on CT or hyperdense. Another one is going to be calcium. Oh, wrong. Too much excess in the calcium. Calcium. So when you have calcium, and a lesion has a calcification, either speckled or coarse, it's also going to be dense on CT. Or if you have a lesion that is extremely hypercellular, and we have some lesions that are extremely hypercellular, but they don't tend to be really white, but there are little tumors that have a lot of little blue cells when you see them in histology. And these tumors tend to be brighter or denser on CT. And the typical one would be kind of lymphoma. Lymphoma, I think, is a great example, or meningioma of these types of tumors. So white is going to be hyperdense. So dark is going to be hypodense. So when you have something that is hypodense, you have three options. The first option is that the lesion around it has a loss of volume. So if you have a lesion and around the lesion you have loss of volume and it's dark, is one thing. The other option you have is that the lesion has normal volume around it, or the other one is that the lesion has mass effect. So the lesion itself is creating a mass inside of the brain. When you have loss of volume around a dark lesion, that translates into brain death or brain that is dying, and we call that encephalomalacia. I'll show you examples of that. Right? When you have mass effect around a dark lesion, we typically call that edema. And they still have lesions where you have a normal amount of brain. When you have a normal amount of brain and you have a dark lesion, usually you have to think about things like demyelination. See, when you see mass effect, you have edema, and there are two very important types of edema that are focal, that are dark in the brain, that you need to check. First is you have to ask the question, does it include or involve the gray and the white matter? Or is it mostly in the white matter? If it's involving the gray and the white matter, we saw that in the previous lecture, that is typically because the neuron, which is the cell that is involved, is edematous. So that is cell toxicity. And where do you have neurons? You have neurons in the gray or in the white matter? Gray. What about the white matter? What do you have in the white matter? Axons. Are axons part of the neuron? Yes. So when you have cell toxicity, it will involve both the gray and the white matter because the axons are also part of the neurons. So when you have gray and white matter, we call that cytotoxic edema. There's kind of a rule for cytotoxic edema. It is that cytotoxic edema happens most of the time because the ATP pump that you have in the cell wall does not work. So you have low ATP. That's why in stroke you have low ATP. So you cannot pump out the sodium outside of the cell. It stays inside. Even though the water is freely flows through the cell wall, it gets kind of trapped because it's adhered to the sodium, and the cell, the neuron, starts swelling up as it needs energy. So low ATP creates cell swelling, and that's what we call cytotoxic edema. It starts a toxicity that is edema because it's dark, and it's swelling up, and the gray-white matter differentiation is involved. So the most important cause of cytotoxic edema is a stroke, but it's not the only one. There's another cause of cytotoxic edema that you can have, which is, say, that the organelles that create the ATP are not working. And that is, for example, in mitochondrial diseases. If the mitochondria we created is not working, then the mitochondrial encephalopathies, which are diseases where the mitochondria is not working, will also make some sort of cytotoxic edema. In this case, because it's not a vascular territory, the cytotoxic edema of mitochondrial encephalopathies tends to be more located in the gray matter because that's where you have the bodies of the cells. There's another time where you can have cytotoxic edema, or another example, that is not stroke, and is when you have an infection of an infectious disease that lives inside of the cell and reproduces utilizing the ATP. And which are the infectious processes that utilize ATP and can create cytotoxic edema in an acute phase? Viruses and prion diseases. So when you have cytotoxic edema, you're going to think about stroke, virus and prions, or mitochondrial encephalopathies. Gray-white matter, stroke, viruses, mitochondrial encephalopathies. Now, if it's only the white matter, we live in Houston and we get floods all the time. If you have an excessive amount of water flowing in the extracellular compartment, not in the intracellular, intracellular cytotoxic edema, in the extracellular compartment, it will go and accumulate where you have the most space, and the most space is in the white matter. So when it floods, because the blood-brain barrier is not working right, the water will accumulate in the white matter, and that's what we call the vessel wall leaking, and that's vasogenic edema, which is the other edema. And when you think about vasogenic edema, you have to think about two diseases, especially because these are mass effects. You have to think that there could be a tumor or there could be an abscess. There are other things that give you vasogenic edema, but those are the main two. And we're going to kind of go through this, but mostly if you have a lesion in the brain, this is the algorithm you should follow. Right? Is it dark or is it white? Is it white? You think about blood and calcium. If it's dark, if it's loss of volume, encephalomalacia. If it's normal, think about demyelination. And if it's mass effect, you call that edema. There are two types of edema in focal hypodense lesions. One is going to be the one that involves gray and white matter, which we call cytotoxic, which can be vascular because of a stroke. It can be because of viruses and prions or mitochondrial encephalopathies. These, the virus, prions, and mitochondrial, tend to affect mostly the gray matter because that's where the somas are. And the other one is vasogenic edema. Vasogenic is kind of leakage of the water. When that water leaks into the extracellular compartment, it leaks into the white matter mostly, and you have to think about a tumor or a mass. So this is kind of the same deal with some of the images. So we can see here that if it's bright, as in this case, you see a bleed, minerals or calcium. If it's dark and you have surrounding volume loss, in this case you see the ventricles being wider and bigger, this is encephalomalacia, chronic things, dead brain. But if it's a mass and the surrounding structures have a mass effect, it pushes the ventricles, effaces the sulci. This is edema. And when the edema is there, then we have to figure out what of the two types of edema it is. If it's cytotoxic or vasogenic. Now, let's start with blood. So when you have blood, you have 5 options where you can have blood. And this is where anatomy is very important. Blood can accumulate in the extraaxial compartment outside of the brain axis or in the intraaxial compartment inside of the brain axis. If it's extraaxial, you have to remember the layers that you have from the skull all the way to the pia mater. But if it's between the bone and the dura, we call that epidural. If it's between the dura and the arachnoid, we call that subdural. And if it's deep to the arachnoid and superficial to the pia and goes through the sulci, we call that subarachnoid. Now, if it's intraaxial, it can be inside of the brain parenchyma or inside of the ventricular system. So you have to define which of these 5 places where we have the blood, right? So this is we'll have a whole lecture on bleeds and how to detect them. Another thing that is very important when you're looking at that is if you have mass effect, this is a blood white, the blood has a crescent shape. We're going to see that that's epidural. It pushes the structures, and when it pushes structures, it can cause what we call herniations. So we have to evaluate for herniations, and I'm going to show you also later what are the types of herniations we have. And when we do the bone windows, we do not only concentrate on the bone of the skull, but we also have to detect how the paranasal sinuses and the mastoids and the skull base, foramen, are. And that's where we do that. That's another part that we do. So Those are going to be part of our next lectures. But with this, we conclude the Welcome to Neuroradiology lecture. I think that this is a real introduction of how CT is helpful, how to remember that you need to do different windows to see different lesions, and also what is a basic algorithm when you have a lesion in the brain parenchyma to know if it's dense or hypodense and how to kind of differentiate what type of lesion it is. So I hope you enjoyed it. See you the next time.